Mr. Alan Betti. I'm a dental technician and responsible for guided surgery in B&B Dental. Today in this webinar we're going to see all the steps about guided surgery, especially how to take the impressions, which material used to take an impression, the preparation of radiological template, implant planning, and the design of the surgical template. Now, I don't know how many of you already use this technique, but I'm sure that all of you have already heard speak about of the guided surgery. So, but we start from the main concept about guided surgery. What do we really mean by guided surgery? Guided surgery or computer-assisted implantology is a method that allows to plan and insert interbone implants in a very easy way, predictable and little invasive for the patient. Predictable because the software allows us to plan the case before the surgery, so that we can already know position, inclination, and really deep of the implants. Little invasive for the patients because we don't need to open the flap. In B&B Dental we have different lines of implant: 3P, EVO, slim, and wide. We can perform the surgical guide with 3P, slim, and EVO implants, except wide because wide is too big to enter into the sleeve, because the big sleeve that we have in B&B Dental is 5.5 millimeter, and the implant wide start from 5.5 millimeters. So in this case is not a problem, because you can start the surgery until drill 5 millimeters, that the biggest sleeve that we have into our surgical kit, and then you can remove the surgical guide and you can bring into the end the surgery in traditional surgery. This is our kit, is completed of all the tools that you can use during the surgery: ratchet, lance drill, mucotum, countersink drills, deep drills, compactors, CRESTAL pins, lateral pins, mounters, everything you need for your surgery. This is the workflow. B&B Dental has created this workflow to make easy all the process, all the steps that the doctor has to follow to arrive into the end of the process without troubles. It's composed of 8 steps, from the diagnosis to the surgery, and now we will go to see one to one all the steps to complete all the process. So the first step is the diagnosis. The diagnosis, so what the doctor has to check, what the doctor has absolutely check before decide to use this technique. The opening of the mouth of the patient, because the drills and all the components into the surgical kit for guided surgery are 9 millimeters longer than the drills for traditional surgery. So if the patient doesn't open enough the mouth, you can't use this technique. Thickness of bone, both in traditional surgery and in guided surgery, you need of enough bone to perform the surgery. Distance between teeth, 6.5 millimeters for the small sleeve and 7 millimeters for the big sleeve. Metal in the oral cavity. Metal in the oral cavity is not a big problem, but we have to check if the patient has metal in the oral cavity, such as crowns, bridges, or big reconstruction, because we have to understand if we need of radiological template or not to perform the CBCT. Second step, taking impression, the impression. Impression just in silicone. For the partial edentulous, you can use the impression B component base and light, because we need of the maximum precision. And for the total edentulism, you can use a silicone like Improve. Develop the model with low retraction materials, are dental stone or epoxy resin. Third step, radiological template. The radiological template, the preparation of the radiological template is different if we speak about of partial edentulism or total edentulism. In case of partial edentulism, you can use a rigid and printable base from 1 millimeters to 1.5 millimeters. Rigid base, not soft, just rigid. And in case of total edentulism, you can use a light curing base and pay attention by bringing the resin into contact with the antagonist teeth in order to improve its stability, like in the picture. So, if you want, if the patient has already a prosthesis in his mouth, you can use a prosthesis of the patient. But the prosthesis must be adherent to the gingiva. You can duplicate the prosthesis of the patient, put the marker on the radiological template, and perform the CBCT. So, where to insert the radiopack markers? Radiopack markers, 1 behind central incisors, 2 on the vestibular surface of canines, and 2 on vestibular surface of molars. For maxilla and mandibula is the same thing. Before performing the radiographic exam, you have to do 2 things, both important. So the first one is check the radiological template into the patient mouth. So you have to call the patient into your dental studio and check the stability of the radiological template for partial and total edentulism. And explain to the patients how to place the radiological template in the oral cavity, especially if you send the patient to the radiological center. You have to explain to the patient how to place the radiological template is much important. This is a form that you have to fill and sign if you send the patient in a radiological center. And there are into this form there are some advice for the radiological center. This is some advice, some setting advice for convene for the doctors that for the doctor that have the convene in his dental studio. DICOM standard is the first setting. Slice from 0.3 0.6 millimeter is a medium resolution, is a good resolution. FOV 5/8, 7/8 is already a good FOV. The FOV is the field of view, the field of acquisition. No anti-scattering filter, don't use some filters. No stitching system. The stitching system is present, usually is present into the combine that doesn't have a big foe, and is a multiple acquisition, usually 3 different acquisition that after the acquisition the software matching in just one acquisition, but is never precise. Computer tomography must be in DICOM-DIR format, medium or high resolution. Medium resolution from 0.3, 0.6 millimeter. High resolution usually is in a dental scan that you can find in a hospital, and a big dental scan, and usually is not present in a combine, but 0.3, 0.6 millimeter is already a good resolution. Don't use the low resolution. 0.7, 1 millimeters is the low resolution. Don't use it because it is not precise. Radiological template well positioned into the patient mouth and well stable. Otherwise, this is the result. The black line means that you have to repeat the CBCT again, because in this case the radiological template is not in the proper position. Avoid to use the fork during the CBCT for the same reason that we have seen in this slide. Because the fork, especially for total edentulous, could move the radiological template, and you have to repeat again the CBCT exam. Use only B&B Dental radiopack markers. And if you use the prosthesis of the patient as a radiological template, it must be adherent to the gingiva, and only and just in case of total edentulism. If the patient has 1 molar, is not a total edentulism. Just in case of total edentulism. If the patient doesn't have any teeth in his mouth, you can perform the double CBCT system. Double CBCT system is a double acquisition. The first one is the CBCT on the patient with radiological template in his mouth in a proper position of the radiological template, and the second acquisition is just the radiological template. You put the radiological template in contact with the teeth on the rest chin, and then you can perform the CBCT. Then you have the possibility by our software to transform the DICOM files in STL files, and you can use the STL files as a model. So, to proceed, we need CBCT in DICOM-DIR format, scanning of the model, and scanning of the model with radiological template. After that, you can send us all the files by WeTransfer, by Swiss Transfer, with the transfer that you prefer, and or if you want by our cloud. Into our software, into B&B Dental software, there is a cloud, and you can insert into the cloud the CBCT, the scan of the model, and the scan of the model with the radiological template, and send us. Or you can share this file with your dental technician, with other doctors in your country, for example, or if you want with B&B Dental. This is our new software. The software is B&B Dental GS. is developed according with our philosophy of guided surgery. The doctor can manage to all the process from the acquisition of the DICOM files to the creation of to the design of the surgical template in a very easy to use and is very easy to learn all the tools. The software allows us to import the DICOM files, import the STL file such as radiological template STL files, STL file of radiological template and the STL file of the model, and align them with the DICOM, with the CBCT, make a panoramic view, insert the nerve in alveolar canal, create a virtual teeth to check the position of the implant, the exit position of the implant, put the implants into the bone, of course, put the abutments on the implants and make the surgical guide and the model. Obviously, so the alignment require just STL files. The STL is the extension of the file, through the planning software allows us to join the DICOM files, model and radiological template in order to proceed with the project. But obviously, to do the project, we need, in addition to the DICOM files and the STL files, also the prescription form that the doctor has to fill and sign, because this form tells us what the doctor wants. So, in this form, you find the position for your name, the place for your name, for the name of your patient, name and surnames of the patients, if you want a code for the patient, the date of request, the date of the surgery, if you have already a date for the surgery, the type of dentalism, the clinical consult. You have to flag yes if you want that your project is done in B&B Dental. Otherwise, you can flag no if you don't want the clinical consult. Implant position, the type, kind of prosthesis, useful information, post-extraction implants, special request, virtual flap, guide extension from one element to other element, windows for the flaps on the surgical guides, and lateral pins. If you want, you can make a request for models, prototyped models, or just STL files, and if you want that we insert the analogs, standard all 3D analogs, and then you can sign the form and send us. So we have two different ways to do the alignment, by radiological template and by teeth, by residual teeth. In this case, you have to use the radiological template if you have a case of total dentulism or a lot of metal in the oral cavity, crowns, bridges, and big reconstruction that make a lot of scattering effect, and you can see the matching point to align the DICOM files between the DICOM files with STL files. So in that case, you need of a radiological template. Otherwise, if the mouth of the patient is free from metal and there are some teeth into the patient mouth, not usually are enough 4 teeth into the patient mouth, but not 4 incisors. not for molars, because we can check the position of the model in the space without teeth. Okay, so if you have two canines and two molars, is good to make to perform the alignment. Otherwise, you have to use the radiological template. The software planning, this is our software, the B&B Dental GS. The planning software allows to insert the implant with extreme precision and to plan immediate or different load, even case for post-extract implants. As you can see, you can put the implant. You can adjust the position of the implant. That triangle is the white triangle is a warning collision. We have 3 different warning collisions in our software. Violet triangle is collision, warning collision between sleeve and soft tissue or anatomy teeth. Red triangle that now you can see into the slide. Okay, red triangle is nerve, is the warning collision between implant and nerve. The safety zone between implant and nerve is usually 2 millimeters. And the third triangle is the light blue triangle, is collision between implant and implant. Usually the distance between the safety zone between implant and implant is 1.5 millimeters. So if you have 2 implants, the space between implants will be 3 millimeters, 1.5 millimeters at implant. So you have the possibility to put some teeth to check the position, the exit position of the implant, and this is the library for the abutments. Into the library you can find all the abutments, different height color, different angulation. For the abutment 15 and 25 degrees. For the multi-unit straight 17 degrees and 30 degrees. And the flat, both for 3P, EVU and wide, and for slim connection. This is a case of immediate load. We did this in collaboration of a doctor that's collaborate with us, and just to show you that with the guided surgery it's possible to do a lot of things. Also an immediate load in a very easy way from the radiological stand to the surgery and subsequent prosthesis in a few times. So radiological template, CBCT, implant planning, the 3D printer to print the radiological template and the model, the preparation of the prosthesis with a metal bar, the prosthesis, the day of the surgery with surgical template, the finished prosthesis, and the prosthesis into the patient's mouth. 4 or 5 days to do all the process. This is our cloud. After the planning, we can send to the doctor, if the doctor wants that the plan is done in B&B Dental, of course. We have the possibility to share the project with the doctor by mail. The cloud works by mail, and we can send at your mail and the doctor's mail the project and the doctor can check the position of the implant, the position of the sleeves, position of the abutment, the position of the lateral pins, all there are into the project plan. Once checked the project, you have to send us the authorization form to proceed with to the print of the surgical template and the model if you want, and you have to fill and sign this form. The surgical template is designed using a CAD that you can find into our software. That allows us to customize the surgical template for mouth to mouth. And it is able to create a surgical template for post-extractive implants. Now we're going to see three different types of surgical template. Let's start from the surgical template teeth supported. In case you have the patient has a lot of teeth in his mouth and the teeth are in health and they are not periodontal teeth, you can use it as a pillar for stabilize the surgical template. In addition, you can use for the greater stability the CRESTAL pins, but just if you want. In case of mucosal surgical template mucosal supported, is not stable because the soft tissue are soft, yes, and in this case you can help the patient to the stabilization of the surgical template with a bite in silicone as in the picture. And then you can insert the lateral pin to stabilize the surgical template, because for the total dentalism is indispensable use the lateral pins, and if you want, in addition, you can use the CRESTAL pins. The first surgical template is bone supported. The surgical template bone supported is stable because the contact from between bone and the surgical template is hard, so is really stable. Is not there isn't problem for this kind of surgical template. So, but like even in this case, you have to use the lateral pins, and if you want, the CRESTAL pins. Okay, just two words about lateral and CRESTAL pins. As we told before, the lateral pins is indispensable in a total edentalism to achieve the stability, and the lateral pins has a proper sleeve, metal sleeve, and proper drill to make the osteotomy. The CRESTAL pins, instead they are of two different diameter, 4.2 and 5.5 millimeter, according with the sleeve that you want to use, and two different length, 7 millimeters and 10 millimeters, in this case according to the soft tissue, the thickness of the soft tissue. The use of them depend of the height of the bone, the height of the soft tissues, and the length of the implant that we want to put into the bone. The sleeves are all in PEEK material. PEEK material is a great material for this using. Is self-lubricating. we can keep a little tolerance, a little gap between sleeve and the drills, because doesn't overheating like a sleeve in metal, because because PEEK is a plastic material. All the sleeve are 5 millimeters long, 5 millimeters of high. The sleeve are the two different diameters, 4.2 and 5.5 millimeter. They have an hexagon on the top, and this hexagon is very important because we can find through this triangle, through this hexagon, the right position of the implant hexagon and the right position of the angulated abutment that we plan as we plan in the project. The sleeve, lateral opening sleeve, are used mostly in the posterior area of the mouth. If the patient doesn't open enough his mouth, it's possible to use this sleeve to get more space to enter laterally with the drills into the sleeve. Sorry. Okay. This is the mounters. The mounters, these are our new mounters. Yellow, 3 different diameters. So, no, sorry, 2 different diameters, but for sleeve 5.5, sleeve 4.2, and for slim connection. So yellow ring is for slim connection. Green or ring is for small sleeve, for sleeve 4.2 millimeter, and blue ring is for the big sleeve 5.5 millimeters. 3 different height of mounters, 0, +2, and +4. And now we're going to see how to use the mounter +2 and +4. So in this slide we can see how to use the mounter +2 and +4. As we told before, the neck of the drill is always 9 millimeters long. But why? Because 5 millimeters is the height of the sleeve, and so we have 5 millimeters to drive the drill into the sleeve in the proper position, and 4 millimeters the space expected for the gingiva. 1, 2, 3, 4 millimeters is always the same. But what if we have 6 millimeters of gingiva? If we have 6 millimeters of gingiva, the sleeve goes in collision with the anatomy. So in this case, to remove the sleeve from the collision, we have to move up the sleeve. So we can move up the sleeve in position +2. So that we remove the sleeve from the collision, but we have to use a drill 2 millimeters longer than the normal sleeve in position 0, okay, to obtain the same length of the osteotomy, and we can put into the bone maximum implant 12 millimeters. So why this thing? Because 12 millimeters of implants, sleeve in position +2, 12 +2, 40 millimeters. 40 millimeters is the the longest drill that we have in our surgical kit. Same thing for the sleeve plus 4. The sleeve plus 4 you can use for the post-extractive implant, where when we have to go very deep into the bone to find the compact bone, and into the alveolar site of the root. But even in this case, the maximum implant you can insert is 10 millimeters length, because 10 millimeters sleeve plus 4, 4 plus 10, 40 millimeters. So the more we increase the height of the height of the sleeve, the shorter will be the implant that we can insert into the bone. Easy. This is the website where you can download our software. You can download our software. You can go, if you want, even on, you find this link even on the B&B Dental website, www.bbdental.it. You can find the windows about guided surgery and the link that you have to find to download the software. The software is it works through your mail, and you have and you can share all your project with whom you want by the cloud. You have to only buy the exportation, 20 euros at exportation, by credit card, and you already and you are ready to work and make the guided surgery with our software. So, new services to the doctor. In the dental field is important, but is our responsible to always research and develop a new method that can rehabilitate even patients who have lost this possibility for different reasons, with not removable prosthesis and able to satisfy aesthetic needs. Because when the patient come into a dental studio, especially in Italy, I don't know in the studio from abroad, but in Italy, ask three things, just three things: few time, lower price, and perfect aesthetic result. So today it is possible to, through some surgical technique, such as guided surgery that we have seen before, and pterygoid implants and juxta grid, to restore patients with severe bone atrophies. This is the services for the clients, for our clients. B&B Dental has decided to integrate new services to the doctors in addition to the guided surgery. And we speak about pterygoid implants and juxta grids, of course. Just one workflow for all the services. For the guided surgery, for the pterygoid implants, is the same workflow. Change a little bit for the juxta grid, but not much. Just a word about pterygoid implants and two words about juxta grids. What are pterygoid implants? The pterygoid implants allows the implant prosthetic rehabilitation of the maxilla affected by severe bone atrophies, where it is not possible for various reasons to intervene using the technique of great sinus lift. This is our kit. The kit is a kit with everything you need for the day of the surgery, traditional and guided surgery. So drill for traditional surgery, drill drills for guided surgery, compactors for guided surgery, compactors for traditional surgery. And the ratchet, straight manual key, everything you need for the surgery. They are our pterygoid implants, same diameter 4.75 millimeters, different length 18 and 16 millimeters, according to the space that you have the patient has in his mouth. Abutment 40 degrees, multi-unit 40 degrees, and long hexagonal key. Just 2 words about pterygoid implants. Now 2 words about Juxtagrid. What are Juxtagrid? Juxtagrid allows prosthetic rehabilitation on the patient who can not be undergo to guide or traditional surgery. A patient that doesn't have a thickness of bone due to serious cause of bone atrophies. So if in the surgical guide we have seen that we can realize a surgical template in a normal way, or if you want you can use the prosthesis of the patient, in that case we have to use just the prosthesis of the patient as a radiological template. So if the patient doesn't have a prosthesis in his mouth, you have to construct a prosthesis, you have to realize a prosthesis of the patient and duplicate it and use it as a radiological template. So in this case, for the Juxtagrid, we need of a radiological template as a prosthesis, the DICOM files, the STL files of the model, STL files of the radiological template, the prosthesis radiological template, and the STL file of the antagonist. And in order to proceed with the Juxtagrids. Printing and design, to be able to proceed with the printing after you send us the DICOM files about the patients, about the part, the maxilla or the mandibula, the part to rehabilitate. We need to clean the DICOM files, and we can do this thing by a segmentation software. Is a very long things, but is much important because we in this case we have to extract just the bone of the patient, and then we can proceed with the design for the Juxtagrid. And then, so we can print the mandibula or the maxilla, so the part that we want to rehabilitate. The design of the grid will be performed by a specialized doctor. If you want, you can design your Juxtagrid, is not a problem, but if you want, we have some doctors that can design, the specialized doctor that can design the path of the Juxtagrid. Standard abutments, diameter 4 and diameter 5 for anterior parts and posterior parts, diameter 4 and 5 and 2 degrees total, 2 degrees cone total for conometry abutment, and transcortical screw 12, 10, 8 and 6 millimeter. This is the measure of the total of the screws, but in reality the working part of the screws is 10, 8, 7, 6 and 4 millimeters. When the Juxta is designed, when the Juxta is designed, they are printed and sent to the doctor for the final inspection. So after you can design drawing the design of the Juxta grid, we can print the Juxta grid in plastic, and then we can send you all, or if you want, if you have the possibility to print, if you have a 3D printer in your country, we can send you the STL file, and if you want, you can print everything you want. Then we send you the software. In that software, there is the possibility to check the position of the abutment, the position of the screws hole, and the screw that you have to use during the surgery. After the approval of the project by the doctor, we go on with titanium printing and subsequent electro-polishing of the Juxta grid. So, in this case, the Juxta grid is finished, and we can send you everything, a box with the part to rehabilitate the maxilla or mandibular and the Juxta grid. So, my lecture is arrived into the end, and see you soon. Bye.